I've taken some images here from a book that I was gifted by a photographer called Tim Booth, which I would thoroughly recommend. And he's provided a plethora of really beautiful images which demonstrate hand anatomy and hand function from an artistic point of view. And I think illustrate really nicely some of the points that I want to get across to you in terms of what can happen if you experience dysfunction of your hand. Because of course the human hand is an expression of creativity. So we're able to create hugely intricate music through the intricate movement of our hands and wrists. And if we lose those, then that function is lost. And there are a number of people whose professions rely on dexterity, the hand and wrist surgeons, stonemasons, among others. And again, dysfunction in that regard has huge consequences on their personal income, their personal pride, their mental health, their physical health. So these are all important in terms of reporting. Every hand tells a story. And in the image on the left, you're seeing somebody who's able to use their hands in a skillful manner to provide food for their family. And in the image on the right, you're seeing somebody who's worked a lifetime as a coal miner and whose superficial layers of the hand have become stained by the material that they work with. And so in a medico-legal assessment, these observations of the state of the hand become important because they tell us a little bit about what a claimant is able to do at the current time. But of course, if your hands are taken away from you, then you lose all of that ability. How do you work? How do you feed your family? How do you eat? How do you conduct basic tasks such as personal hygiene? And the hand is particularly special, certainly in terms of trauma and orthopedics, because it has a huge aesthetic implication. So when you interact with people as humans, you tend to look at their face and you look at the back of their hand. So scars across the back of their hand or deformity affecting the back of the hand are very easily recognized, and they can be very stigmatizing. And claimants often feel under pressure to tell us about pain or stiffness or loss of function. And actually, it's only really when we start to drill down on the aesthetic implications that you understand that the psychology of this injury is really quite huge. When you look at people, you may not notice that their hand has a finger missing, but you'll notice if there's one finger sticking up in the air that doesn't bend, and that's important. So when you appoint your experts, you're looking for somebody who's got a really intricate knowledge of anatomy of the hand. And the anatomy in the hand tends to be fairly constant, and you can predict it fairly well based on surface markings. So this is my hand. And in the image on the left, I've drawn the course of the median nerve, which runs through the forearm and then gives branches to the muscles that supply the thumb, and then sensory branches that go down to the 1, 2, 3.5 fingers. And that's important because your thumb represents probably about 50% of your hand function. So the fingers interact differently. When we talk about hand function, we talk about the need for the thumb to be able to dialogue with the fingers. So if you imagine wanting to talk to 4 people who are sitting on a park bench, then if you position yourself right next to them, your dialogue and your interaction with them will be really quite limited. So you have to position yourself on a separate chair, slightly opposite them, in order to be able to have a conversation with each of those people in turn. And the same is true of hand function. You have to be able to rotate your thumb out of the plane of the fingers in order that it can appropriately dialogue with the fingers and perform the tasks that we ask it to do.
So that's enough about me. Let's talk about what you're here to hear about, which is spinal pain. So this is quite a useful graph. So this graph shows the global burden of lower back pain in different populations across the world. So it shows at the bottom lots of different age groups, 20 to 29 and so forth, going up towards 80. And it shows the degree of burden of lower back pain using DALYs, or DALY. This is disability adjusted life years. It's very commonly used now to describe the burden of disability associated with medical conditions. And a DALY is the amount of time that someone spends in their life that is reduced due to either early death or less than full health. So it shows how much disability is related to that pathology. As you can imagine, lower back pain is fairly prevalent in terms of disability, particularly in Western Europe. So it's not a global pandemic, but it really is a problem in Western Europe, particularly. And it's difficult to say exactly why, but it's likely to be an interplay of things like mental health. So depression is very prevalent, other comorbidities such as obesity, other lifestyle factors, and other socioeconomic or poverty-related factors. What's even more interesting is that if you look at studies, the amount of degeneration or the incidence of degeneration on spines hasn't increased anywhere near the rate that the disability has. So it's not as if just more people are having degeneration or pathology on scans needing more surgery. It really is that back pain has persisted, but it's just becoming more symptomatic and more disabling, particularly in Western Europe. So when one assesses patients with back pain, it's important to remember that biopsychosocial approach is crucial, because that explains why someone has increasing disability either naturally through disease progression or after an index event than other people. And that's really crucial when a medical expert examines such a patient. And it's also then important that we think of why certain people are at higher risk. So is it that in Western Europe, we're having more depression, more psychological problems that are leading to this increased disability? And then we may open a bit of a can of worms in terms of vulnerability. And that's an important thing to assess as part of a report. The problem is spinal pathology is not straightforward. You can't just do an MRI scan and then say, well, someone's got a disc prolapse, therefore they're far more likely to get disability as a result of this disc prolapse. As you'll see on the next one or two slides, it's not as straightforward as that. And I think that from a medical legal point of view is a very common pitfall that people can run into. So this is a widely quoted study, and it forms the basis of a lot of medical legal reports. So it was a huge analysis done in 2015. So the authors took 33 studies that looked at the results of an MRI scan in patients who do not have symptomatic back pain. So they had MRI for some other reason, and then the authors looked at the spine and thought, well, let's see what's happening with regard to the spinal pathology in these people who are asymptomatic. So it was a huge study and very interesting conclusions. They say that most people who have back problems on an MRI scan are asymptomatic, and the rate of asymptomatic spinal disease is very high. So this says that if you take 10 people at a bus stop and scan all of them, people who have pain and don't have pain are as likely to have the same findings on an MRI as due to chance. So just because you have a disc prolapse doesn't mean you have pain. Just because you have a disc prolapse doesn't mean you're going to get long-term back pain. It's much more nuanced than that.
So these are the classifications of the emergency cesarean section. We have category 1, 2, 3, and 4. Category 1 is usually when we need to deliver the baby like now, and the recommendation is to deliver the baby within 30 minutes. And this happens if there is an abruption, cord prolapse, fetal hypoxia, or persistent fetal tachycardia. Category 2 is when, for example, we are suspecting that there is sepsis, but actually we cannot. We have time to give antibiotics and prepare the woman and make sure that she gives informed consent. And we do have about 75 minutes to do that. So it's a bit of a more controlled situation. Category 3 is in a semi-elective environment, is when we are starting an induction of labor and the induction doesn't work and the patient does not respond to the medication. There is no dilatation. Both the baby and mother are healthy and happy, so you can do it when the elective theater is ready. And a category 4 is a scheduled operation when you can do it. We can just schedule it a few weeks before, and this is done the same manner as any type of elective procedures. So the first case is a 28-year-old woman. She books low risk. She's 38 weeks pregnant, and this is her first pregnancy. And the patient presented to the emergency department. She was sent upstairs to the labor ward, and she had spontaneous rupture of membrane. The midwife, basically, who saw her, does a vaginal examination, and she identifies that there is a cord coming out from her vagina. So what happens in that situation? Then the midwife will need to call for help. Then the patient needs to be placed in a knee chest position to relieve pressure. I will show some pictures of what this means, so that the cord is not pressed, or the head is not pressed against the cord, and so you can buy time for the women to be moved to theater. Then the obstetrics team comes over, and they identify that this lady is not fully dilated, and she will need to have an emergency cesarean section. So this lady's knee chest position, and she has no analgesia on board, and you have a few minutes to take this woman to theater, put her under general anesthetic, and or a spinal if the anesthetic team is happy that they can give a spinal faster than a general anesthetic. And you have a couple of minutes to go through the risks and benefits of a cesarean section in a case where actually you have no other option, and if you don't do anything, the baby will die in utero. And this lady actually now thinks that she needs more time, and she needs to discuss with her family if this is the right thing to do. Now, the issues with the consent in this case is it really informed? Because you don't have a lot of time. You need to make sure that the patient is fully informed about the risks of the cord prolapse, and the risk that if she doesn't do anything, that her baby will die, and the need for an urgent delivery. Make sure that this lady has the capacity to receive all this information. And of course, at that point, now the woman is very anxious, and how much information can she receive at this point? So potential litigations in this case is if there is a delay in treatment. In this case, we need to do a category 1 emergency cesarean section. I will go through the categories of the emergency cesarean after the next case. So there is a delay in court in taking this lady to theater. For example, then the baby dies, then they can sue the hospital that there wasn't a fast enough response to deliver the baby within 20 or 30 minutes. The other risk of litigation is the obstetric team performs an emergency cesarean section, delivers the baby, but actually they injure the bowel and they cut the ureter, and which is one of the risks. But actually, because of the urgency of the situation, these risks were not explained to the lady, and she said that she never knew about that. She wouldn't have accepted to have a cesarean section. If you don't document that you have explained and you discussed all the risks with the woman, then there is an issue, and this can go to court. So it's very important, because in a cord prolapse situation, it's very difficult to do all this, to explain to the pregnant patient who has a few minutes, where you have a few minutes to deliver her baby, that there is a list of 30 potential injuries that she can sustain if she goes for a cesarean section, but actually the risks is 1 in 500. But you have to tell her, because she needs to understand and sign an informed consent. The other thing is there is an consent from the anesthetic point of view, because giving a spinal or general anesthetic, there are risks as well. So actually the consent is not only from the obstetric team, is also needs to be given and explained by the anesthetic team as well. So in this case, they were able to communicate effectively. They did an emergency cesarean section under a general anesthetic, and the baby was born within 25 minutes alive with good EPGAR scores.
Speaking of challenges, this is a common problem and often a challenging one. It's estimated somewhere in the region of 20 or 30% of outpatient neurology appointments within the NHS have a clear functional component. So this is something that we come across quite frequently. And it's important just to note that if you look at the subjective ratings of those patients who we see, actually their quality of life is not so good. And then I think the other point is to say is that this doesn't necessarily go away. Some patients get better, yes. Many, sadly, do not. There are a number of common myths with respect to functional neurological disorders, which I've tried to outline here. I won't read them out, but needless to say, these do crop up not infrequently in a highly pressurized NHS. So, for example, locally, we've been doing quite a bit of work with our ED staff, who I have to say are fantastic at picking up functional problems, but clearly not a particularly good environment to address someone with a functional neurological disorder when chaos and scary stuff, frankly, is all around you. There is often, and I don't necessarily restrict this to caring staff, a perception that these patients are trying to manipulate the situation, and undoubtedly some do, but they are a minority. There is a understanding that most have suffered childhood abuse, but it is of course common and not necessarily restricted to childhood. MAD is a word I tend to avoid, and my psychiatric colleagues similarly. It's just not helpful. And over the years, it's become very apparent that this is neither the sole domain of mental health services nor neurology. And really, that's really where we're trying to go with services for such patients in terms of.
So actually, the first thing says epilepsy doesn't exist. A very bold claim for an epileptologist to make, but actually it's not epilepsy, it's the epilepsies. So you have lots of different conditions make up this term, epilepsy. And I think it's really important to say that we have this significant number of disorders that fall under this banner of the word epilepsy. So it could be you have a child with infantile spasms. You have a different child who has a tumor. You have a child who has a genetic epilepsy, such as Dravet syndrome, secondary to an SCM1A mutation. They all get that word epilepsy. It comes in so many different flavors. It comes in so many different causes, so many different outcomes, and so many different treatments. Why is that important? Well, not all epilepsies created equally. Some is profoundly difficult to treat. Not all epilepsies are secondary to a brain injury, and some are secondary to a brain injury. And more importantly, not all epilepsy has a good outcome. 80% of people who have epilepsy will succeed with their first two appropriately chosen drugs. After that, you're entering into the world of significantly difficult to treat epilepsy. Some of them will be surgical candidates, and as such should be evaluated. When one treatment works for somebody, and it may well be the same treatment that harms another patient, and that's something we're going to come to in Dravet. Just keeping in mind epilepsy in other cases, because as I say, I could talk about this all day. Some epilepsies start out one way, so you might have a very early infantile epilepsy that evolves to West syndrome, and then eventually evolves to Lennox-Gastaut. So you may find, well, why is Why did Dr. Taylor at the age of 2 say this child had West syndrome, but now I've asked to see this child again and they're 12 and they've now got Lennox-Gastaut. Sometimes epilepsy evolves, and be aware that we may say, keep an eye on this case, because actually revisiting things may give you better prognostication. Your neonatal seizures in HIE may well re-emerge later on as an infantile spasm or West syndrome, depending what way you like to refer to it, and then it could eventually evolve into that Lennox-Gastaut. So very difficult to make those cases early, and that may have direct impact on the quantum, on what your long-term outcomes are and what the care needs are in the long term. And the consideration, will the NHS be enough? In the UK and Ireland right now, there are about 170 practicing paediatric neurologists covering about 80 million people. That's not a lot of us. So it's really to keep in mind. There is the private sector, but again, that's still woefully under-resourced. And actually, I'm going to be very honest, a lot of the investigations I do, a bit of private work, I can't access to the same way I can in the NHS. It's one of the great things about the institution itself. Just want to mention about post-traumatic epilepsy. I'm sure I've got a lot of defending firms and a lot of claimant firms pricking their ears up at this one. So first thing, we do recognise genetic factors. There's some really great studies that actually we know people who have a family history of epilepsy are more prone to developing post-traumatic epilepsy. Whereas we will probably be coming into a phase in the coming years where we will be seeing the research looking at are there markers that could tell us you're more prone to developing it. I think it's a really exciting phase, and a lot of research and a lot of discussions happening about lots of willingness, and I think a lot of financial backing in the coming years. But we also need to think about the underlying background. We are in a phase of genetic epilepsies. You know, a childhood absence epilepsy and you've had a minor head injury, it doesn't really add up to saying the childhood absence epilepsy was caused by the very minor or very major head injury. It may well be a genetic epilepsy at play. You may have other issues that you have to explore. And I think that's where having a pediatric neurologist look at a case and pull together whether or not there is that clear causation. It's also really, really important to say, it's lazy diagnostics to say, oh yeah, has epilepsy, had a head injury, and not consider that wider phenotype. Because one, as a clinician, I could be putting the child on the wrong treatment, but two, I could be directing you as either a claimant firm or a defendant firm the wrong direction. And the other thing just to say is latency. Can you rule it out? Well, actually, latency doesn't automatically rule out an event. It can be well described 10 plus years later, up to 20, depending on the severity of the head injury. You may well have a latency period and there be a relation to the post-traumatic epilepsy. So don't be saying, well, it's 10 years, 15 years down the line, I can automatically rule it out. You can't. But also, you need to take into account every bit of circumstance around that individual as a person.
Today, and I'll whittle on for about 40 minutes, but to go through some of the pathophysiology and mechanisms that we understand are important with traumatic brain injury in children, and then just to talk about some of the aspects of management and how that impacts outcomes from these children. So it's really important to remember that children are not young adults. You can't extrapolate what we understand, what we know, how we treat adult traumatic brain injury to children. Firstly, the mechanisms that cause TBI. So I use the term TBI to mean traumatic brain injury. So the mechanisms that cause traumatic brain injury will vary depending on the age. So for instance, in infants, they're prone to diffuse and repetitive injuries of non-accidental injury, which differs very much from the accidents, the bike accidents, the car accidents that older children will suffer. Secondly, there are constitutional factors in children that result in different injuries, a different biological response to injury, such as they tend to have a larger head mass than older children and adults. They have weak neck muscles, particularly younger children, infants will have relatively pliable skulls, and all of those factors influence how a traumatic brain injury is experienced in a child. And furthermore, there are metabolism, there are neurobiological idiosyncrasies, if you like, of the younger children that impact how a traumatic brain injury behaves in younger children. Traumatic brain injury is a very heterogeneous disease, and therefore it is helpful to, in terms of when we're treating it, when we're trying to predict outcomes, to break it down, to try and categorize it. And this can be done initially on the basis of the mechanism. So we recognize that there are open and closed injuries. In terms of closed injuries, we're quite used to seeing children who are involved in high-speed road traffic collisions, low velocity falls. That tends to be more in elderly people, assault occasionally in children, but relatively rare. And I've already mentioned non-accidental injury, which is the commonest cause of a traumatic brain injury in an infant, really. Occasionally we get an open head injury, so we get the odd air rifle pellet. I've had a crossbow once recently, but they're relatively rare, and there are different aspects of those head injuries that make them different from closed head injuries. TBI is a heterogeneous disease, as I've said. The other way to think about it are the type of lesions that we see associated with the head injury. So there can be a skull fracture, and that might be of the base of the skull or the vault, so the top bit of the skull. In terms of intracranial injuries that we see, we often see a diffuse axonal acceleration-deceleration injury, for instance, with high-energy car accidents. And there are more focal lesions that we see, and you'll probably be familiar with some of these terms, such as a hematoma, which means a blood clot within the brain substance, versus a contusion, which is a bruise of the brain substance. The brain substance is enclosed in the leathery membrane called the dura. So we have bleeds that are outside the dura, next to the bone. Those are extradural hemorrhages, hematomas. We have bleeds that are beneath the leathery membrane adjacent to the brain. Those are subdural hemorrhages, and sometimes we have bleeding within the brain substance on the surface as well. So there are different lesions that characterize different types of traumatic brain injury.
And I'm going to talk today about brain injuries in children. So brain injuries can occur for a variety of reasons. They can be due to birth injuries, which are a major topic of medical legal cases, traumatic births leading to conditions such as periventricular leukomalacia, hypoxic ischemic encephalopathy. Brain injuries are more common in children that are born prematurely, and then they can occur after birth as well due to conditions such as hypoglycemia, or as a consequence of surgery for tumours or anaesthetic complications, and then, of course, due to trauma. So we're all more familiar with the effects of brain injury on general development and growth. As you probably know, brain injuries early in life can lead to conditions such as cerebral palsy, with physical issues and developmental delay and effects on speech, mobility, cognition. But as well as that, brain injuries can lead to a visual impairment and also visual processing issues. And this is a condition that we term cerebral visual impairment. So I'm going to talk a bit today about vision processing and development in general, about cerebral visual impairment, and some of the other ophthalmic conditions that can occur with brain injuries. So this is just an image taken from the CVI Now website, and it shows the eye and the connections of the eye to the brain through the optic nerve, the optic pathways with the lateral nucleus, and then the optic radiations taking the nerve signals from the eye to the brain to the visual cortex, which is the occipital region at the back of the brain. And from there on, there are other areas of the brain, such as the parietal and temporal cortex, which are also involved in visual processing. So this is another image looking at the eyes at the top there and the brain behind, and you can see that the optic nerves take the nerve fibers to the chiasm, where the half of the nerve fibers from each eye cross over. And so the nasal half of the retina, the fibers that are connected to the nasal half of the retina of each eye cross over at the chiasm and then go on through the optic tract and then the optic radiations to the brain. And so the left visual cortex receives all the information from the left half of the retina from each eye, and therefore is responsible for vision in the right visual field, and the right visual cortex is the other way around, which is why you can get these hemifield visual field defects. And brain injuries can affect any of the parts of the visual pathways and the parts of the brain that can affect visual processing. So I'm going to talk a little bit about visual development and maturation because it's relevant to this topic. Visual development starts at about 6 weeks of age, but as you know, there's a lot of variation in that, and some babies can be very visually alert from birth, and others don't develop their visual behaviour until a few weeks old. Most babies are able to fix and follow readily by about the age of 2 months. Premature babies don't start developing their vision until their corrected age. In other words, they can be older when they start developing their vision. Binocular function, which is the ability to use both eyes together, develops in the first 6 months. And visual development overall occurs up to the age of about 7, 8, 9 years. And that's for all children, whether they've got a brain injury or not. So during that time, if there's something that interrupts visual development, which could be an uncorrected need for glasses or the presence of a squint or an injury to the eye, child can develop amblyopia, where the visual development falls behind in one eye compared to the other. And this is managed, as you may know, with glasses or, if appropriate, or patching or atropine eye drops to penalise the better eye. And the success in treating amblyopia depends on how well the child is able to wear the glasses and how well the patching is adhered to. Delayed visual maturation, which is a condition which is relatively common, and it's when a child has poor visual attention and inability to fix and follow from birth, and the vision doesn't start to kick in until later than you'd expect, really. So typically a child has poor visual behaviour and the parents are concerned that they're not following and they're not visually alert, and it usually improves at about 3 to 6 months of age. Type 1 delayed visual maturation is seen in babies who are otherwise completely well, and their vision develops normally and there's no neurological or other abnormalities. And type 2 occurs in children that have other issues going on, which can be neurological conditions such as a brain injury, or sometimes problems with the eyes themselves, and those children can have persistent visual impairment even after the initial improvement. Another example, a different type of brain injury this time. This was a child, very sadly, who was in a road traffic accident at the age of 5 months when they were in a rear-facing car seat in their parents' car, and the car was hit behind by a lorry and was shunted into the vehicle in front. They had a CT and an MR scan which showed multiple head injuries with fractures and bleeding and effusions of the brain. And they had seizures and developmental delay as a result of this severe traumatic brain injury. 2 weeks after the road traffic accident, the child was noted to have poor visual behaviour and exotropia with the eyes turned outwards. And also the examination of the back of the eye showed that they had retinal hemorrhages in both eyes, which was basically bleeding just due to the severe nature of the head injury. At 3 weeks after the injury, they had sunsetting eyes, which is when the eyes sort of intermittently turn downwards, and abnormal pupil reactions. And this can be a sign of hydrocephalus, raised pressure within the brain. They didn't have papilledema, but they did have imaging evidence of hydrocephalus, and so they had a ventricular peritoneal shunt put in for post-traumatic hydrocephalus. And I saw them when they were age 5, and they had reduced visual acuity in both eyes, quite poor vision, one eye worse than the other. They had a divergent squint and sort of signs and symptoms of cerebral visual impairment, which were very variable vision, difficulty with edges, difficulty with steps and stairs and copying shapes. And it was not possible to assess the visual fields as they had learning difficulties, and they were eligible to be registered as severely sight impaired. So just to coming to the end now, but just to mention that there are pitfalls in medical legal cases of children with brain injuries. I've had several cases now where the child's had poor vision and it's been thought to be due to a brain injury. One case, a child had a birth trauma and had very poor vision, and it turned out it was not initially apparent that the child had a problem with their retina, and they actually had a rare genetic eye condition, which was a retinal dystrophy, which affected their vision rather than the birth trauma. And I've had a couple of cases now where the child had hypoglycemia following birth, and so the claim has been around the management of the postnatal hypoglycemia. And the child's had very, very poor visual behaviour that has thought to be attributable to that. And then on examination, as the child's got older, it's been seen that the child has a condition called optic nerve hypoplasia. You can see this image here, where the optic nerve is really tiny and is underdeveloped. And that's the cause of the very poor vision for the child, nothing to do with the negligence. Optic nerve hypoplasia does go with endocrine abnormalities that can lead to hypoglycemia. So hypoglycemia may have been related, but wasn't related to the poor vision. So it's important to exclude non-ophthalmic causes of, ophthalmic causes of visual loss.
What is the growth plate? So unlike the bones of, I presume, everyone on this chat, where we are all skeletally mature, our bones don't grow. They can heal if we have a fracture, but they don't grow. They don't change neither in length nor in shape otherwise. Children's bones do. So you can see here on the slide, there's a line through the bone there, there's another one there, and there's another one there, and that's called the growth plate. So that's where the bone not only gets longer, but gets bigger as a child grows. It is a relative area of weakness, and therefore is susceptible to injury specific to the growth plate. We know that growth plate injuries are very common because children commonly injure themselves. It is not uncommon for the growth plates to be injured, and about 15% of fractures in those under the age of 16 will involve to some degree the growth plate. Now, very few children who have injuries to the growth plate end up having problems in the future, but it is those in whom the growth plate has been affected that we need to keep a close eye on them. Boys typically are much more likely to get injured than girls because they tend to be naughtier and have a higher participation in contact sports as well, and risk-taking behavior in general. There are some sites which are more common. So firstly, the hands and the fingers, but also what's known as the distal radius, or the wrist, and the distal tibia, which is the ankle. They are the most common sites. So I say wrist and ankle are probably the most common. Injuries in the bottom end of your thigh bone, so just above your knee, and what's known as your distal femur, they are rarer, but they are the ones most susceptible to having what's called a growth arrest, and we'll talk a bit about that. The various growth plates in all the body, and the reason this is important is because different parts of the growth plate, different growth plates contribute different amounts to the actual growth of the limb. So, for example, if we talk about the upper limb, the one at the shoulder and at the wrist contributes about 80% of the growth of the arm, whereas in the lower limb, it's around the knee where the bulk of the growth of the growth happens, as you can see over here. Okay, let's talk briefly about the legal aspect, and then we'll talk about some cases. So when we talk about clinical negligence, obviously the duty of care aspect is established right off the bat by the doctor-patient relationship. There can be a breach of duty either in case of mismanaged growth plate injuries at the start, or more commonly, I suspect, missed injuries. So people who had an injury, the injury was picked up on, the injury at the time was probably sufficiently well managed, but no one picked up on the fact that this child was at risk of developing a growth arrest. And as we know, we need to measure this against the BOLAM test refined by Bolitho. And in most pediatric orthopedic practices, if you have an injury of any sort, be it traumatic infection, whatever, around the growth plate, the expectation would be that that child is followed up for a certain number of months, if not at least a couple of years. Causation can sometimes be tricky because it can be difficult to differentiate between how much of the problem is caused by the actual initial injury, that means the fracture or whatever injury there was to the growth plate, and how much of it was caused by the subsequent treatment or lack thereof. And that can be very difficult to ascertain. We know certainly that if you have a fracture around the growth plate, you are at an increased risk of having a growth arrest. And even in children who are managed completely appropriately from start to finish, there is a risk. In those cases, it's very easy to attribute the causation to the actual injury because they were managed appropriately. If you add to an injury an element of less than ideal management, that can make things a bit more complicated. There are various aspects that often get put through the various experts for the claimants and for the defendant. Typically, it involves the early stages. That means failure to obtain the right imaging, or the right imaging has been obtained, but the interpretation has been wrong. And that normally sets the wrong tone for the remainder of treatment, because if you've not picked up on a potential growth plate injury and a potential growth arrest, you are unlikely to be appropriately followed up to make sure that even if you do get a consequence of your injury, that is appropriately managed. And therefore, early detection and appropriate treatment with referral to a pediatric orthopedic specialist is really important. If you do have a growth plate injury, it is likely you will need several surgeries. And I say surgeries because there is little role for non-operative treatment. If you have a small difference, let's say you have a growth plate injury, you have a leg length discrepancy, and it's going to be somewhere between 1 and 2 centimeters, you do have the option of treating that without any surgery and accepting you've got a post-traumatic leg length difference, and you can treat that with things like insoles and orthotics. But if you have anything more than that, or you have lots of growth left, the only way to treat this is with surgery. And correct me if I'm wrong, but I believe that the limitation in England and Wales is 3 years, which means in pediatric cases that takes you until the age of 21 at least. When it comes to quantifying the damage in growth plate injuries, often it's fairly straightforward. If you have an isolated growth plate injury which is appropriately managed, the fracture would have caused a growth plate injury, and were it not for the injury, they wouldn't have had any growth arrest. Quantum can be much harder to establish, like with all pediatric cases, because you need to establish what the prospective earning potential and life goals in general for that patient are, and that changes. How many of us now in adulthood have the same dreams and aspirations, or even fulfill our childhood dreams? Probably not many of us. Second case, so this is not a post-traumatic injury, but rather this is a child who has an infection, which involves the growth plate. So again, this is a child who had a bone infection, so osteomyelitis is the technical term for bone infection, but she also had what's called a septic hip, so that means an infection in the joints. And she presented to hospital with pain in both hips and reduced range of movement, and she was really unwell, and she was started on all the appropriate antibiotic treatments, etc. And part of the management involved surgery to wash out these infected hips. Also, the child is a very complex from a behavioral point of view, which made all aspects of her care quite tricky. She had several washouts, but despite that, the bone infection kept getting worse and worse. And the team in charge were unable to get on top of her bone infection, and that kept spreading throughout the bone of her thigh and also all the muscles around the hip and her hip joint itself. So she had several surgeries, I think, before she got to my care, probably about 7 surgeries. In the end, she unfortunately went on to suffer what's called a pathological fracture, which means that her left hip broke, which is an exceptionally rare and can be a devastating injury in a child of her age. So the right hip had recovered, the left hip had recovered reasonably well, but the right hip unfortunately was still, you can see the bone looks very different, and unfortunately the bone broke, and you can see the break just there. She was then treated for that, and that management was initially non-operative with a cost, which is contentious, but probably was not the ideal care for what's known as an intracapsular fracture. That didn't work, so she then went on to have another operation to try to get the bone to heal. So there you can see the bone is still broken, but she had an operation to try to realign the forces across the hip joint to see whether that would cause the fracture to heal, but unfortunately it didn't. And at that point, she was referred to my care, and I was involved in her case. And so we got some cross-sectional imaging, as always, CT scan, MRI, and you can see here that that bone still hasn't healed, and there are changes within the bone to show that there is active infection going on. So took her through a complex case MDT with other surgical colleagues, but also with my bone infection colleagues. And ultimately, I took her to theatre for a fairly complex operation where I undid what had been done with the previous surgery, made the hip back to the shape it should be, took away all the infected bone, and put loads of metal into the right place to hold it all in place, and included one procedure called the surgical dislocation of the hip, which is a fairly complex procedure where we try to treat injuries of the head and the neck. And she's done very well. So because things are now back to normal as they should be from an anatomical point of view, and because all the infected bone, etc., has been taken away, she has done very well, and she's back to tap dancing. The hip is now starting to grow again, and she's got a very good range of movement.
What investigations will have taken place before you see them?
Usually they would always have like some form of imaging, and the most common is CT scan, so computerized tomography, which is a quick way of looking at gross abnormalities of the brain. So that's predominantly the main investigation, and obviously they would have some bloods because trauma and head injury happen in a context, and so, and one of the main contexts sometimes is intoxication, for instance. So they would have normally some blood to see whether there's some form of intoxication going on or some contribution from medications, or and it's very important, like now that we're aging and the population is aging, and we see a lot of people on anticoagulation, so we just need to make sure with the blood tests whether if they're taking an anticoagulation, whether they are, what the level of coagulation is, because obviously that is also crucial when it comes to predicting, forecasting what's going to happen, what may happen and what may not happen.
Aging's quite a sore point for me. I had quite a big birthday this week.
Yeah.
So when delay happen, I think the first question would be, is this delay negligent or non-negligent? Because this is a cornerstone, okay? Non-negligent delay is obvious. It is a delay that is outside the ideal. You know, you should have seen the patient, ideally, I should have seen the patient within a week, but I've seen the patients within 2 weeks or 3 weeks. However, that, you know, still within the reasonable, within the constraints of the job, and the patient was managed according to the acceptable standard. So yes, not ideal situation, but it is acceptable situation, and you will not find any, you know, responsible body saying this is wrong. It's just not ideal. Now, like we said, the negligent delay is when there is a departure from the standard of care. I should have seen the patient within 2 weeks. It's not that I didn't see the patient within 2 weeks. That delay happened for 2 months or 6 months, for whatever that reason is. And that particular delay had a knock-on effect on the subsequent events. And therefore, when anybody, after like myself as a medical expert, come and dissect and say, well, that should have been, 3 or 4 months earlier, and therefore this delay resulted in such an event, blah, blah, etc. And then we go to the, factual and counterfactual arguments. And then the other thing is, which is important with the negligent delay, especially with the uncertain group, and I keep coming to this, because the consent and the safety netting are quite important when we have more than one option. I do not want to, kind of frighten you. It could be a cancer, but my gut feeling such and such. What do you want me to do? If I don't consent the patient correctly, letting them know that cancer is a possibility when I am not sure, then I am likely breached my consent process. And any delay that follow or any negligence that follow may be based on that, wrong consent process. Or we decided we are going to do the watch and wait, but I did not provide my patient with the safety netting, i.e. I'll see you after 4 weeks, or I will give it such and such, but if there is a bleeding, if there is discharge, if it's getting worse, this is the number. If I don't do that, then I might be negligent. So these are quite important. When you send us the letter, which is obviously there something happened, and I'm sure it goes through your initial assessment process, and then you say, Mr. Al-Azam, this and that, I want you to have a look and let me know what do you think. Then I, kind of myself and the experts like myself, we ask a few questions, and I, try to pin it down. These are the 5 fundamental questions. What actually happened, which is practically the question that you are, the event, the main event that you are asking in your letter. And then from my initial assessment, was it reasonable, the action of that particular healthcare provider, whether it is an individual or organization? And if it wasn't, what should have happened? Is it ideal or is it negligent? Sub-ideal or is it negligent? And then the following one would be, was there a missed opportunity to address the problem at an earlier stage or in a different way? Have we missed the opportunity? And if we missed that opportunity, or that particular group missed that opportunity, what was the impact on that particular patient? Was that impact tangible and material, or what was just a process of inconvenience? And these are quite important. And then from there, we provide you the opinion and start giving you the answers, whether it is a breach of duty accusation, and then we start trying to reach with you to a degree that we build up in a non-biased way, give you the more certain answers, because I think when you ask the questions, you want to have as certain as possible. Sometimes it's very difficult, and sometimes we cannot give you that. We try to give you the 2 sides of the coin to make sure that you yourselves, as a professionals, are going to take care of these cases to have an informed choice or decision to decide how you are going to approach it, or whether you are going to approach it or not from the beginning. And I'm not going to lecture you about the legal parts. You are the experts. I am a medical expert rather than the legal expert. But these are the frameworks that we work with. The BLAM and Bolithio, between the reasonable and justifiable. And then from a consent perspective, the Montgomery and the McCulloch. And then when we look at the causation, you would like us all the time to give you the Bailey argument rather than the Greg's argument. And of course, as a clinicians, we are bound up by our legal body, which is the General Medical Council. So these are our frameworks where we work from. In a cancer pathway, and for all the cancers, whether they are gynecologicals or non-gynecologicals, you notice all the time, and you are all aware of that, there are national and local guidelines and regional guidelines, and sometimes there are international guidelines for a particular disease. Some of them overlap. There are some variations between the guidelines here and there. So from a 2 weeks with referral where the cancer is, the general guideline is provided by NICE, which is the right to get access to diagnosis and then the safety networking. And then from a cancer perspective, for example, our gynecology cancers, we have the Royal College, and then we have the specialist societies. The British Gynae Cancer Society, the our Endoscopy Cancer Society, the British Cytology, PSCCP, and so forth. So there are a lot of professional bodies who try to streamline the work and make it a little bit easier for everybody who works in, and make the work fairly consistent. And then also we all work within our MDT, and the MDT, the multidisciplinary team meetings, they happen locally at a, what we call it, the peripheral hospital level, secondary care level, and then we have the regional MDT. And all these, provisions are there to provide the best care, to prevent harm, and to make sure that the patients get the best deal. So what is the journey of the patient when they have a problem? Of course, they don't go to their GP or to INNEG or to their clinician with a diagnosis. They go with a presentation. I have pain, I have bleeding, I have discharge. That presentation initiate assessment, and that works in within the history, the examination, the investigation, whether it is a blood or imaging, and so forth. From there, there is an initial assessment. If it is the GP, they might feel it is better managed at a secondary level. They send the referral letter to, whether depending on the urgency, to the secondary care. And if that's thought to be a cancer or suspected cancer or confirmed cancer, it goes to the MDT. And within the MDT, they decide what would be the best approach of treatment. And this is another way, this slide is presenting it in a slightly different way. And the, kind of following the initial assessment, the way I always see it as a clinician, that presentation fall into 3 categories. With the person who did the first assessment, as I said, can be, the GP or somebody else. It is cancer, and therefore that patient will go through the 2 weeks wait referral, and we have a structured pathway of what to do with that. It is not cancer, and I'm pretty confident that it is not cancer. Then the next question would be, can I manage it locally? And if so, I initiate the management as a care provider. Or, yes, I know that it isn't, I'm confident it's not a cancer, but it's beyond my scope of provision, whether I am a GP or a different specialty, so I refer to the proper specialty. And there are situations, and the third category, it is uncertain. It looks like benign, but I'm not sure. It could be. And here is the gray area, and I think this is a very important area. And from there, do I need to follow that up myself, or yes, I am not certain, but I refer to the secondary care, and that where the referral is. And there are various, maybe it may not be the cancer suspected pathway, but I could say to the, for example, as a GP, to the clinician, can you see this patient urgently? I'm not quite sure. And the clearer the referral, the better for the patient, and also the less hassle for that person who did the referral case.
I had a miscarriage at 16 weeks a couple of years ago. And having spoke to a professional about it, it wasn't somebody in the medical profession, but I was told that I would need to be induced and give birth. Whilst this is hugely different to a birth at full term, it was still labour and it was still birth. When discussing this with this professional, they said, why do you need to go through that? Do they not just cut it out of you? That opened up a whole world for me that I thought did not exist. I thought that actually people would say, oh, I'm really sorry to hear about that. Is there anything that I can help you with? Please let me know how you are. It was a difficult conversation to have, both from my perspective and theirs, because the conversation instantly turned awkward. It instantly became an uncomfortable situation for both of us. And whilst we need sometimes blunt honesty, what we don't need is coldness and cruelty. And whilst it might seem like you are helping us by being honest, we need honest compassionately. Asking questions, personal questions, they might sometimes feel a little bit uncomfortable, but once you've asked them, the whole conversation is likely to change. Personal questions such as the baby's name. Does your baby have a name that you would like me to use? This could be initials, it could be a surname, it could be a nickname. Through the football team, we have heard every name, I think, possible. We have baby Cloud, we have baby M, or we have Poppy and Dotty.
I'd like to consider 4 areas, I call them the 4 C's, when I'm interpreting problems, claims in maternity, because they all play really important factors in poor outcomes. They're choice, maternal choice, context, consent and continuity. And I'll just take each one of these on their own. So choice was a concept that was really promoted by Baroness Cumberledge in the report that she authored, Changing Childbirths, in 1993. And at the time, it was quite revolutionary. And the report focused on empowering women and their caregivers to decide on the place of birth and how they would like their birth to go. And I don't think anybody that read that report wasn't supportive of maternal choice. The problem we've got with choice in maternity is that choice is absolutely wonderful when things are normal and physiological. Where we come unstuck is where women, patients make choices when the situation is pathological, because that's where the claims arise. There's lots of analogies to the airline industry in maternity, which I generally find quite annoying because they're not often analogous. But one thing that we can compare to is the airline industry with choice. It's a bit like when you go into a plane and you choose your seat, 1D or 11A, as I'm sure lots of people are choosing now. Airline industries promote choice. They expect you to choose your seat and they're very comfortable with you doing so. Where they're not so comfortable is if you choose your seat and then you refuse to put your seatbelt on. They won't let you take off. In maternity, women will choose their seat and they'll also choose not to wear their seatbelt, and we still have to fly the plane. And then when we hit turbulence and there's a head injury, somehow they will take it back and say, well, you should have insisted I wore the seatbelt. So you can see that choice can have negative connotations when things become pathological. At the moment in maternity, we're really in the spotlight. I'm sure you're all aware of the Morecambe Bay and Ockenden reports. Every unit in the country is under scrutiny. And because of the media hype, women nationally have lost trust in maternity services. And more, they're declining intervention because they've lost trust in the caregivers and they're concerned that they will have worse outcomes if they take the advice of the people looking after them. This has become so prevalent that my own trust, we've set up a weekly out of guidance declining intervention meeting to discuss women and the implications for them declining the advice that we're giving them. The human factors involved in declining intervention when situations are pathological are absolutely enormous, and that then contributes to worsening outcomes.
Here you can see the top left is an example of pin cushioning, where you can see there's been a almost circular scar, and what happens with the scar is it will contract slightly, so it'll shorten, and in doing so, it brings the tissue that's in the middle, it makes it a little bit plumper, like a pin, like a cushion, and that's more evident, you know, in real life than in a 2D photograph. Then bottom left, what we've got is what's called a dog ear. So you can see that the wound has been sewn up, but they've been left with a little proud bit of excess tissue at one or both ends of the wound, and that can be unsightly. And then on the right hand side, you can see an example of tethering. Here there's a skin graft scar, and it's tethered to the underlying muscles, and that will be, again, as I said earlier, most evident when you move the limb. So consider getting a video of that rather than a normal photograph. Right, so the difference between a scar and a blemish. So the definition of the words of a scar is that it's a permanent mark in the skin. So you can't, if people say, oh yeah, I had a scar for 6 months, but now it's gone, you know, that is nonsensical, because where's the permanence of that? If that is the case, it was a blemish. Now, you can only truly diagnose a scar by feeling it, because then you will palpate the scar tissue, whereas a blemish will be completely flat. You cannot feel it, and will improve with time. Nearly always will improve with time. The blemish can be hypo or hyperpigmentation. So again, if your surgeon gives you a report that's done remotely, they should say that they can't really distinguish between a scar and a blemish. I mean, there are some photographs where, you know, it's barn door obvious that this is raised, like some of the ones I showed you earlier. But when it's less, when it's more subtle than that, then you can't really tell. Therefore, you can't give a full prognosis.